I appreciate the opportunity to talk with you this late in the day. My name is Jim Czerwonka. I'm a compliance specialist with SDG Blue. It's not Jimmy Czerwonka. I go by Jim. So just wanted to clarify that. This session today is what healthcare can learn from banking. And just to go over our agenda and hopefully keep us on track. What I'd like to do is do an introduction of who SDG Blue is, what we are, what we do, that sort of thing. Hopefully explain some of the industry expertise that we have, build some credibility for you, and then move into healthcare versus banking, the results. And two of our guys, Mike and John, are here today. They did some number crunching for us, so we've got some hard numbers to support some of the theories that we had and premises. Then move into the Office of Civil Rights audit results and see what differentiates between what we put together and what they found and some of the similarities. Then move into some of the theories that we've created as a result of the work that we've done, going to industry meetings, reading, studying these industries. And then last, move into practical ways to address security and compliance. And a lot of that is really commonsensical type things, but it will help in the healthcare arena. So who are we? SDG Blue is an IT professional services firm. We focus on three primary areas: security and compliance, managed services, and network infrastructure. We were founded in 1991, and from day one we were involved in healthcare IT. We're headquartered in Lexington. We have offices in Louisville, Indianapolis, and Cincinnati. Within the last 2.5 years, we merged with Blue & Company, the CPA firm, and so we have a similar footprint that they do. Blue & Company has, their book of business is around 60 to 70% healthcare clients. So they've got about 400 CPAs and advisors, primarily focused in the healthcare arena. We specialize in banking and healthcare, so we're heavily involved in bankers associations, healthcare association, HIMSS, healthcare, financial management, all that sort of thing. And so we really have a large focus in this area. And our clients range from New York to California, but we primarily focus on regional clients. So we're servicing Indiana, Kentucky, Ohio, Tennessee, and West Virginia. And today we have John Askew, who is one of our analysts, and Michael, who are here up in the front. Patrick is our Director of Consulting Services. He's in the back. But Michael and John primarily did a lot of the number crunching for the next slides we'll be seeing. All right, so consulting services primarily focuses on security consulting. We're doing strategic planning. We're doing technical and non-technical assessments. I do a lot of the compliance consulting, so risk management is really huge right now. Focusing on HIPAA, high-tech, meaningful use, GLBA, PCI. We do FERPA for colleges. And then FFIEC and HIPAA exam advisory services, and the HIPAA audit services as well. DR planning and testing. I help clients put together disaster recovery plans and do a lot of testing with them. And we do analytics and project and our program and project management. And so several weeks ago, when we were picking around some ideas on what we were going to present for this conference, we did some brainstorming internally, and it was like, we sure are seeing a lot of unusual activities, a lot of high-risk areas, a lot of critical areas within healthcare versus what we see in banking. I mean, there's a lot going on in healthcare from a security standpoint that hadn't been resolved. HIPAA has been in place since 1996. The privacy rule went into effect in 2003, and the security rule went into effect in 2005. From a banking perspective, GLBA went into effect in 1999, and the IT examination handbook came about in 2002. So they've had, a lot going on in these industries, but just to give you some background on how, I guess, how long we've seen compliancy and security in healthcare versus banking. But anyhow, so we did some brainstorming, and it was like, well, what are the major areas that we're finding these issues in? And so John and Michael went back for the last year to our IT security assessments, and they pretty much crunched the numbers in 4 primary areas, which was malicious activity, so malware on the system, wireless assessments. We also did social engineering, and then endpoint vulnerabilities. So we'll get into that. So we took that information and then we compared it to what we're seeing from the Office of Civil Rights results, both from a technical and non-technical standpoint. And then hopefully we can attempt to explain the differences in the theories section as we go through those slides. But our desired outcome was pretty much to provide factual information that our healthcare institutions can leverage to improve security and compliance. And we've got some slides in here to hopefully help our healthcare clients. So from a banking standpoint, you know, we first got into malicious activity, which what we do is we have an appliance, we take it to our healthcare clients, and we plug it into their network. And so within typically an hour of plugging it in, we're going to find some sort of malware on that network. Malware being software that is capturing sensitive information, such as electronically protected health information, some of those 18 identifiers, you know, that identify patients. We're going to see maybe software on there that's used to create, you know, disruptions in the operations of the network. So it may be software to allow someone to access the network. So anyhow, what we're finding is that 36% of our clients that we did work on had active malware on their networks, where they had one infection per affected client, which was almost, you know, and in healthcare, we found double that number. So 80% were found to have active malware on the network, and almost 4 times as many infections per affected client. So what that tells us is, you know, we've got a lot of issues out there, and Fonneman Institute pretty much indicated that about 54% of the healthcare facilities are worried they don't even have a detection mechanism in place to detect this malware on their networks. So what this tells us is that they don't have robust incident response programs in place. And if one of these malware, you know, exploits is pretty much capturing information, doing some kind of, you know, click fraud or whatever, you know, there's nothing on that network that's going to tell our healthcare client that they have an infection. And then, you know, from what we've been doing, just from a basic administrative safeguard standpoint, you know, out of about the 10 or so risk assessments that I've done so far this year, you know, none of the organizations have an incident response plan in place, and it's not been tested. So from a wireless standpoint, what we find is that banks typically don't integrate a wireless network into the production environment. So it's, you know, the banks are totally different. They have a back office, people come in from 8 to 5, they go to their desk, they sit down and turn on the desktop, you know, they work for 8 hours and then leave. Where it's different on the healthcare side is you've got nurses and healthcare professionals out there taking care of patients. So they've got handheld devices, they've got laptops on carts that they're keying information in, walk through the halls of a hospital or healthcare long-term care facility. They've got wireless access points throughout the hallways. And that data is being picked up from a wireless standpoint and used in the production environment. So very little segmentation there. So what we're finding is that when we do these wireless scans, in the last couple instances, we found that when we did the scan, that the guest network essentially allowed our guys access into the production environment. They weren't, segregated in any way. So, and the controls weren't in place. So they were able to get into some of the production application systems that contain the electronically protected health information. So the big thing here is, segmenting that network properly. When we do these wireless scans, what we're testing is the policies and procedures and making sure that, everyone in the organization is aware that we have a wireless policy and a procedure in place. But then also we're testing the security and awareness training programs. And again, that's a required item by HIPAA, but out of the 10 or so hospitals, healthcare organizations I've done the risk assessments for, 95% of them didn't have a security and awareness training program in place. Typically they do it when they onboard people and that's it. Where it's totally different in banks. So the banks pretty much have an ongoing security and awareness training program. From a social engineering standpoint, what we see here is human beings are the hardest variable to control. So when we did our testing, both in banks and in healthcare organizations, we found that we had 100% response from the organizations that engaged us to do the social engineering activities. Meaning at least we had one person fall for the trumped up email with the company logo on it that asked them to click on a link, enter their credentials, whatever it might be. So we did have a 100% hit rate there. From a banking standpoint, 30% of the targets responded to the phishing attack, which was almost 16% less, or a third less, of what we had from a healthcare standpoint. Endpoint vulnerabilities. What we did is we looked at inactive or outdated antivirus software on the networks. And so 33% of the banks essentially had ineffective or outdated antivirus software, and 20% of the hosts had critical issues. About 48% of the hosts had high-risk issues. So we had, on the critical side, we had 1 per vulnerable host, and on the high-risk side, we had 5 per vulnerable host, high-risk issues. So the high risk, when we run our scanning tools, pretty much broken down into critical and high risk areas. And so that's kind of how we segment it. High risk being those exploits that you typically don't see, that are maybe new, that offer that ease into the network. On the healthcare side, we saw almost double the amount of ineffective or outdated antivirus. 32% had critical issues, or 2% of vulnerable hosts. 50% of the hosts had high-risk issues. And if you look at it, it was almost 3 times greater in the healthcare side than what we saw in banking. So what's that lead us to believe? Well, that they've got pretty much a better patching solution in place at the banks. It's more robust than what we're seeing in healthcare.
Can you characterize the type of healthcare client that you're talking about here?
Yeah, well, they're ranging in size anywhere from small, moderate healthcare organizations, long-term care facilities,
Provider,
hospitals, yep. Rural hospitals. So, yep.
I work in a bank. We don't have any security or training network vulnerability. We're going to be very vulnerable to this risk.
Oh yeah.
Which is a bad thing. And I know I'm not as familiar with hospitals, but I know there's a lot of regulation there too. So what's the difference? Because I think part of it is that we're looking at not to work bank because people get risk.
Right, and that's
the lack of regulation.
And that's what we'll get into in the theory side. Yeah.
Sorry.
Oh, that's okay. All right. So, you know, we did our kind of research, we came up with the technical aspects and what we found, the non-technical. You know, from a non-technical standpoint, you know, organizations don't have written policies and procedures. They typically don't have a written DR plan that's been tested. You don't have a written incident response plan. You know, a written security awareness plan, a written risk assessment, blah, 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 you know. So from an Office of Civil Rights standpoint, we took those technical and non-technical findings and kind of aligned them with what's going on with the Office of Civil Rights. And so, just to give you a little background, in 2011, the Office of Civil Rights engaged KPMG, which is a CPA firm, advisory firm, audit firm, and they created an audit process for the HIPAA guidelines. Okay, and in 2012, they rolled it out and started doing audits of small, medium, and large-sized hospitals, physician practices, health plans, health insurance companies, physician practices, all that. So they did 115 of them during 2012. Earlier in the year, around May of 2013, they released the results, and that's pretty much what's on these slides here. But what they found is that a vast majority of those audited failed to comply with mandatory requirements. So if you look at the HIPAA requirements that are listed out in the National Institute of Standards and Technology, special publication 800-66, there are pretty much the required items, which means I need policies and procedures, DR plans, security awareness, I need technical safeguards in place, and then there are the addressable ones. So I've got a workstation, I want to isolate it so that people walking by, and it's, you know, out of public view, people can't view that information, those 18 identifiers on the screen, okay? So, but what they found is that one of the major causes was lack of awareness of these requirements. And I can't tell you how many times over the course of this year that I've talked with owners of long-term care facilities, I've talked to CIOs, directors of IT, and many of them they've heard of HIPAA, they have no understanding of what the security rule says about the HIPAA requirements. So, complete lack of awareness of the requirements. Other causes, lack of resources, both financial as well as human capital, incomplete implementation. Worked with a hospital up in Ohio. They had one network administrator who pretty much took care of a 125-bed hospital and the physician practice across the road. He had started implementing endpoint security a year ago. He'd also started implementing encryption, and it had gone on for a year and it still wasn't implemented. So the guy was pretty much working, 24/7, didn't have enough time to finish the projects. And then there's a complete disregard for the requirements. On the Office's Civil Rights website, the Wall of Shame, there is a case study of 5 party acquisitions in Arizona that they were using Google Calendar to schedule their patients. They had put their patient documents up in Google Docs. They didn't have policies and procedures, and they didn't train their employees on those policies and procedures. And so the Office of Civil Rights came in, and essentially they said, the doctors said, hey, we're not going to follow, we don't care. So the Office of Civil Rights went in repeatedly. They finally came in, found them 6 figures, and now they're the poster child for, how not to do it from a HIPAA standpoint. So it's out there, it's pretty interesting to read. So by far, the Office of Civil Rights said that security was an overwhelming area of concern. And then lastly, most of these organizations didn't perform a thorough and accurate risk assessment. And I've seen the risk assessments be 4 pages long, kind of a swag on, gee, we got some risk in this area, to very elaborate. And we'll cover that as well. So what's the breakdown as far as safeguards or controls? Out of those 115 hospitals that were audited, 42% didn't have administrative safeguards in place. So they didn't have the written policies, procedures, documents, all that good stuff. 41% of them didn't have technical safeguards. So they didn't have user activity monitoring in place. They didn't have authentication. Yes, they didn't have authentication. That was correct. And then 17% were physical safeguards not being in place. So they didn't have locks on the server room doors. The wiring closet doors weren't locked. There was an organization in the northwest that didn't have locked wiring closet doors and were fined over $1 million because the wiring closet doors weren't locked. So what are the biggest security issues that the Office of Civil Rights found? Authentication, user activity monitoring, contingency planning, media reuse and destruction, and the risk assessment. And this is a breakdown by security audit issues by area. You'll notice user activity is pretty much #1, and #2 is contingency planning or disaster recovery.
Could some of that be just because they don't understand exactly, when somebody says do a risk assessment, some people are saying, well, is it just my systems, is it just this area, this area, this area, and instead of encompassing, everything from human risks to, systems A to Z that everything the organization touches.
Well, if you look at the meaningful use requirements for attestation, we're talking about an IT risk analysis. So, it's an IT risk assessment or risk analysis. All right. So, what are some of the theories? These are not factual, these are SDG's theories. But audit frequency and impact, banking audits have been the norm for a long time. With the handbook being in place since 2002, you've got the examiners that have pretty much a process in place for coming in and doing an exam. You got internal and external audit that are all involved in these audits. I've been in the business, so, done a lot of those audits. Regular testing equals improved security. So, you've got all these examiners and auditors coming in over and over. They find an observation, make a recommendation, implement it, improve security. Bad audits equal bad results. You're going to have higher FDIC rates, which is going to affect your competitive advantage. Could be higher risk ratings. So, or other banks may be less likely to purchase you or look at you and help you out if you are in a bind. From a healthcare standpoint, lack of regular IT security and compliance audits. Up until 2012, nobody was going in and doing any exams or audits on these healthcare organizations. So really since 2005 when that security rule went into effect, you haven't seen anybody really doing much audit work, at least on the federal side. You may have some of your public accounting firms or consulting firms going in and doing some more audit support work, maybe looking at general computer controls, some application security work, maybe application controls, but nothing like what you've seen at the federal level from the exam standpoint in banking. And then lack of teeth to the audits. There haven't been any fines or penalties, not until last year. And the thing is the Office of Civil Rights is self-funded. So last year their budget was $28 million. They fined about $4 million. This year the budget was $32 million. So guess what? They're going to go on to out and try to find $32 million worth of fines so that they can pay for it. So, no, it won't. It will not be difficult at all. From a cultural standpoint, banking, risk of poor information security is well understood. I'm protecting your assets. If I got bad security and I lose your money, it's going to be front page news. You're not less likely to, make your deposit with me and keep your money there. They're focused on protecting the customer's assets. Whereas in healthcare, the #1 priority is saving lives and taking care of the patients. And a lot of times, accessibility by that doctor to that patient information, say during a surgery or an operation, something like that, they want to get that patient information as quickly as they can. They don't want to remember a password. So that trumps the security in many cases. Data is often legitimately shared with more third parties. I mean, you're seeing outbound, data being sent to collection agencies, third-party clearinghouses for processing, the government. I mean, I sit down when I do the risk assessment, we sit down and we do a data flow diagram. And I mean, this, one hospital I went to was small, it was a rural hospital. We started whiteboarding it. It was like, well, I think I got one doc who reads x-rays on the weekend. Well, by the time it was over with, we had seven different organizations that at varying times of the days and on the weekends read the x-ray for that hospital. And so, just it's out there, it's going out, and it's coming in. Complex services supported by multiple vendors, systems, and technology. I did a DR plan for a moderate-sized hospital and found that they had 1,500 applications on their system. So very complex. They got the handheld units, you got an MRI unit, you got this, you got that. So, quite a few vendors. The thing is in many of those healthcare organizations, they pretty much leave the door open for those third-party vendors to come in at any time and fix that application in case it breaks, because they're running 24/7. And then security is not driven from the top. Again, that doctor will pretty much dictate, I don't want passwords on that system because I don't want to remember them. So coming changes to healthcare, audits to become more common. There's going to be teeth to these audits, fines that are coming down from Office of Civil Rights, which is going to be tied to Medicare and Medicaid reimbursements. Fines for violations, both at the federal and the states, because the state's attorney generals can also levy fines against healthcare organizations for violations of HIPAA. Penalties for breaches. Just in September 23rd, the HITECH Act went into place. So there are new guidelines for breaches, the number of records tied to the number of dollars pretty much that need to be paid as a penalty. You're seeing consolidation of systems and reduction of vendors. A couple of weeks ago, I went to a session. They talked about the EMR, EHR vendors. There's about 400 that develop application systems. Well, out of those 400 that develop those application systems, only 15 of them meet the meaningful use stage 2 requirements that went into effect October 1st. So the others are pretty much, they have to spend the money, get the resources, and put in those requirements.
Jimmy said the ties to Medicare and Medicaid reimbursements, does that affect the hospital? I mean, I'm just thinking that a hospital is going to have to make sure these policies and procedures are in place, but the doctor's still saying don't put the password in the system. They're independent of the hospital.
Not in many cases. No. But, just a couple of weeks ago, we had an incident like that where, for years the doctors pretty much said, don't put any passwords on that system. And now they're actually going to, name character password.
Yeah, they're going to have to.
Yeah. But I mean, it's kind of slid by for years. Now that you're coming out, the Office of Civil Rights is coming out with fines and penalties. You're going to see probably some of this tighten up. So, from a practical steps standpoint, just creating documents, policies and procedures. That was the #1 finding out of 115 hospitals. 42% of them didn't have written policies and procedures and written documentation. So update existing documents, create any missing ones. There's about 62 policies and procedures that should be written in order to comply with the HIPAA requirements. And then address breach notification, because that just went into effect. So what kind of incident response plan do you have and address breaches? Business associate agreements. Again, the changes that went into effect September 23rd. Have you, updated your business associate agreements? Covered entities used to be the only ones that needed to comply with these HIPAA requirements. Well, now it's business associates. So SDG Blue, if we're going in and we're doing a security assessment or risk assessment, and we have access to any of those 18 identifiers that are on your network that identify your patient information, and we're involved in that process of creating, maintaining, storing, transmitting data, then we fall into that category as a business associate, and we pretty much need to comply with the HIPAA requirements. And so, we need to sign a business associate with you as a client. So if I'm an accountant, maybe a consulting group, a shredding group, somebody that shreds documents, that sort of thing, have access to that EPHI, I'm going to sign a business associate agreement. Authentication, a couple months ago we went out and we did, Michael and John did some work at a hospital, and they found that they had over 1,000 users, and that Active Directory password enforcement was not enabled. And in order to get into their clinicals and financial systems, it just required someone to enter essentially their last name, first initial, hit enter, and they were into the system. I mean, this is 2013, So, and when we asked, it's like, well, how come you don't enforce it? And it was like, because the docs don't want it. So, they finally went through realizing they needed to do something, so they're implementing an 8-character password. Don't share so creating policies and procedures for log-on passwords, not sharing IDs and passwords. Again, you're out there in a physician practice, they may be sharing passwords and IDs because the doc doesn't want it, want to remember a password. Implementing two-factor authentication. So many of the social media websites like LinkedIn and Facebook are using two-factor authentication. We use a product called Phone Factor. So when I connect into my VPN, I enter my password, hit enter, I get a phone call on my cell phone, and it says, would you like to authenticate? Hit pound, and when I hit pound, it says you successfully authenticated. Phone Factor is now part of the Azure product. It was bought by Microsoft. So another layer of security there. And then define sanctions. Sanction policy is one of those required HIPAA items. So what happens when I go out to, one of the floors and everyone, all the healthcare professionals are pretty much sharing passwords and IDs? First time it's going to be a verbal warning, hey, don't do that. Second time it's going to be a written reprimand. The third time I'm going to terminate somebody because I've asked you 3 times. User activity monitoring, taking information from the logs and analyzing it, correlating it, that sort of thing, is a real mundane task, and it's very costly to many healthcare organizations, small, medium, or large, it doesn't matter. SDG Blue, I have to do a plug here real quick, but we've come up with pretty much a managed service SIM solution for our clients to offload that task. I went out to a large hospital chain and talked with them, and I said, so what do you do for log management? And it was like, well, every Monday I've got 4 network engineers, and we all get together for 4 hours, and they sift through the logs from the previous week and see if we can find any anomalies. I was like, okay, that's great. So it's a big chore to go through and, pretty much what am I looking for? What anomalies am I looking for? I've got one client, and they're looking for failed login attempts, and then we're looking for after-hours access into the network. So who's accessing the network between 1 and 4 a.m. in the morning? So coming up with what do I want to report on? What am I looking for? Frequency of doing some of this work, from an audit standpoint, auditing those logs. And again, having policies and procedures and definitions around what reports I'm generating and what I'm looking at, needs to be defined. But the thing is if it is defined and you're audited and you're not doing it, you're probably in worse shape than if you had it documented. So we're looking at, again, where that electronically protected health information is on the network. So where's it being created, stored, maintained, and transmitted? And we're going to look for those logs and any anomalies around those specific areas. Contingency planning. Again, out of about the 10 plus risk assessments I've done this year, about 9.5 of them did not have a written DR plan. Okay, the 0.5% had one that a vendor developed for them, and that they were actually testing at a hot site. So what they're looking for here is pretty much the technical plan versus the business continuity plan, which focuses on how to keep my business unit up and running if I've got a down system. Media reuse and destruction. Think for a minute beyond PCs and laptops. Now you're looking at copiers, and I think Mitch brought it up this morning, but one of the television stations did a news report a couple of years ago where they went to a warehouse and they bought 4 copiers and took them back to some expert, and the guy essentially took those hard drives out and found all kinds of electronically protected health information on those hard drives. So not only copiers, but also when you're doing the risk assessment, think about voicemail, because it's got a WAV file on it, or any type of recording that may be stored that contains electronically protected health information. Some patient calls in and says, hey, this is Betty Jones, and here's my diagnostic code, and my address and everything else. How are you storing it? How are you protecting it? And what are you doing from a destruction standpoint when you get that old phone system that's 14 years old? You rip the hard drives out, or you just donate it. Again, looking at USB drives, CDs, and hard drives. So, I've been out, and one client, and I talked to the network admin, and I said, so what do you do with your backups? He goes, I put them in my backpack, and then I get on my motorcycle, and I go 10 miles across town, and I put those hard drives on that shelf in a nursing station. I was like, oh, that sounds real secure. So, implementing policies and procedures regarding media reuse and destruction is a HIPAA requirement. Storing them securely. I worked with another client, and they used a shredding company in New Jersey, and that shredding company took an empty steel case with a lock on it, shipped it down from New Jersey, and they had one on site full of hard drives because they didn't reuse any hard drives at all. The guy took that steel case, put it on the truck. The truck was empty. It was a semi-trailer truck. It only had that steel case on it. They took it up to New Jersey, and they shredded them. And they shredded it using DoD and NIST standards. There's actually a NIST standard called 888. And they tell you how to shred it, and they also talk about shredding paper and what minutia it needs to go to and all that sort of thing. So they shredded it according to NIST, and then they gave them a letter of destruction. So the last area, which touches on risk assessment, is a 9-step process, and we use the NIST 800-30 document or guide for that. And so when I'm going in and doing a risk assessment, I have a template that I use, and I go through and I do a system characterization. So I'm looking at where that E5 is pretty much created, stored, maintained, and transmitted. So I'm taking really an inventory of all the devices that contain electronically protected health information, whether it's a handheld device, it could be a hard drive in a drug dispensing machine, could be a copier, could be a voicemail system, servers, whatever. So I'm capturing all that information. I'm capturing the business processes. I'm capturing the data flow, inbound and outbound, both internal and external. So I'm doing a data flow diagram. And then I'm getting the SSAE 16s or the SOC 2 reports from any third parties. So say I'm backing up data to a third party. I want something that's going to talk about those controls, those weaknesses, give me information on their systems as well. So I use that in the risk assessment. Do a threat determination. So I'm going to go through and I'm going to look at the threats, the human intentional threat, which is pretty much a hacker, the human unintentional threat, which is the network admin that's taking care of the 125-bed hospital, the physicians. He's, totally untrained, but he's installing my backup solution and my endpoint, security solution as well. Also, environmental threats. I went to a hospital and I looked in the server room. I looked up and I'm like, hey, what are these pans doing up here on the server rack? And they said, well, the pipes drip, so we've got these drip pans that we put on top of the servers. So I was like, oh, okay, I get it now. And then also from pretty much a natural disaster standpoint. I was at a small hospital and I was kind of walking through and I said, yeah, when you get hit by a tornado, just kind of joking with the director of IT. And he looked at me and he goes, 5 years ago we took a direct hit. I was like, uh-oh. He said, yeah, at the school across the road, the tornado picked up the gravel off the roof and it acted like buckshot and just blew out every window in that side of the building. He said, fortunately, I had my data center in the basement on the other side of the building. So we look at all those different threats and capture that information. Then we go into the vulnerability identification. So that's where we use the NIST guidelines. We typically do an IT security assessment first before we do the risk assessment. So Mike and John use the tools that we have. They're doing the scans and picking up the vulnerabilities that they can identify. And we're using that information when we do our risk assessment. Next, I'll do a control analysis. So I'm looking at current state controls and future state controls. Just as an example, say I had an unencrypted laptop with 29,000 patient records on it from a newly implemented EMR system. I'm a CFO at the hospital. I go home over Thanksgiving weekend last year. I take that home. The next door neighbor's kid breaks into my house. He steals my laptop that's unencrypted. Okay? He also steals some food, I guess for Thanksgiving, I don't know. But anyhow, that's gone. Okay, so I've got an unencrypted laptop. I don't have any policies or procedures in place around how to store electronically protected information. I don't have a cable that I use to chain that laptop down when I'm traveling or when I'm in a conference room, So I don't have the administrative control in place. I don't have physical control in place, and I don't have a technical control in place. All right? So what happens? It's stolen. I now have a breach. Oh, by the way, I don't have a breach policy in place or a process in place. I don't have an incident response plan in place either. So what I just described was an actual occurrence that happened at Gibson Regional Hospital in Princeton, Indiana last year over Thanksgiving. And so determining what the control structure is, both a current state and a future state, is used in our risk assessment process. So what's the likelihood determination? Well, what's the likelihood of that threat vulnerability taking place? Well, Fonneman Institute, which is an IT research firm, says that about 12,000 laptops are lost or stolen each week in airports. That's each week. So I'd say, well, there's probably a high likelihood, or it might be very likely, that my laptop gets unencrypted with 29,000 patient records is going to be lost or stolen. Okay? So I do a rating, likely, unlikely, very likely. Then what impact does it have to the organization? So what impact does it have monetarily, from a reputation standpoint, and from a legal and regulatory standpoint? I can tell you, having a laptop that size lost or stolen in a small community where you've got a lot of heavy hitters sitting on the board of directors has a big impact to the reputation. And today it's probably cost them a couple $100,000. If you look at that versus how much it costs to encrypt that laptop, it would have been probably less than $200. So what impact does it have? High, moderate, or low? And then, so what I do then is calculate out what the risk determination is, taking the likelihood times the impact, and I come up with a high, moderate, or low impact of the organization using stoplight type, red, yellow, green colors. And then we make a control recommendation. So in our instance where we had an unencrypted laptop, we didn't have policies and procedures, and we didn't have a cable to lock that laptop down, I now make my recommendation to go from a high-risk situation to a low-risk situation. And then lastly, all the results, all this documentation I put together, I need to store it someplace for 6 years according to the HIPAA requirements. So I need to store all my policies and procedures. When I make a change to those policies and procedures, I need to retain it for 6 years. I need to store the risk assessment. So, something like SharePoint may work for you to help store it because it's got the versioning and it's got the audit trails built in. And so that's also the basis that I use now when I have a significant change to the architecture, operating systems, application systems in the hospital, even from a personnel standpoint. So with that, hopefully I've given you all some information from what we're seeing from a local standpoint with the work that we do from more of a regional standpoint. What you're seeing at the national level from the Office of Civil Rights and what they're finding, and pretty much what they're finding mirrors what we're finding in our client base. And then some, just some real high-level areas to address that's going to be, what the top 7 or so findings are from an Office of Civil Rights standpoint. So, with that, happy Halloween. Just wanted to open it up for Q&A. Yes?
So I know you said that there's going to be increasing pressure from like Medicare and all that. What about any foreseeable impact on the volunteer? Because there's more, it's opening it up more, yet there's still, you're still going to be dealing with the same issues.
From a security standpoint, from what we've seen, people are still apprehensive about spending any money because they're pressured right now, many of these hospitals, healthcare organizations. One long-term care facility I had 2 locations, and was like, hey, you want to do an IT, security assessment? He goes, well, I tell you what, I don't want to spend any money, and I know if you ran your tools against my network, you take it down because it's so fragile. So, even when we go in and make these recommendations for policies and procedures, some of these simple things that, you can do on your own, people aren't really doing it. And a lot of the mentality is, I'm going to wait until I'm caught, until the Office of Civil Rights comes in and catches me. But what they're doing now is that you attested for meaningful use stage 1. Well, what they're doing is they're asking healthcare organizations to send in that risk assessment and other documents. And if they don't meet the muster, you're pretty much they're gonna do an adjustment to the attestation funding is what they're calling it now. So they're gonna start taking the money back. So that's what we're seeing. Any other questions? Yeah, Dave.
At our hospital, we've been encrypting disk on laptops for several years, using full disk encryption, and it works great. One challenge is that we have that extra password that people have to type in, and it slows the login process. As you mentioned earlier, physicians are not always willing to accept that. So one thing that we were entertaining and haven't implemented yet is we have tested some deep freeze. In some areas we've been using it, but in non-clinical areas, deep freeze is a way to just basically, upon rebooting the machine, it returns back the way it was. So the code data is stored on that device at all. And I haven't looked into it from a regulatory standpoint, to see if that would suffice as a substitute for full disk encryption.
I'm not familiar with products.
I'm not either.
So you say that on reboot is completely fresh and no
Exactly.
So when you shut it down, how much data is
It's on.
data gone, or is it waiting until it reboots to override it? I guess that would be, I'm not familiar with the product either.
Yeah, these breeds we've been using for years, and I've had to get one of my tech guys to explain it. I don't know the specifics myself, but it basically does not allow you to store data like your browser history and all that, everything. But to your point, I don't know if you shut it down, if that data is technically there, and if you can interrupt the boot process where it wipes it, if that's the case. I don't know.
I think that's the key there. I'm talking more about it.
Okay, great.
And I think depending on when you shut the machine down, is there still data if somebody can access it during that part of time?
Yeah, that's a good point. Thank you.
That's it from our standpoint. Thank you all for attending. Appreciate it. Yes. That's what we feel like after we've done our risk assessment. I know.
Yeah.
Oh, yeah. Phil was on track.
It was very, yeah, it was.
Did I answer your questions?
Oh, yeah, absolutely. Yeah. That's it. My question is that we won't ever get associated with
No. Yeah. Yeah, with Football Brothers, Football Blue, or Blue Brothers.
Honestly, I mean, yeah, it was